Hello, let's talk about the importance of the complete comprehensive exam on almost every new patient. I don't do any definitive work on a patient until I've done a comprehensive exam, except for getting them out of pain. Why? We're sort of in an era of toothache dentistry where people go in to see a dentist, tell them they've got a tooth bothering them, and the dentist fixes that tooth. I don't do that because it's all connected. I remember I had a lady from Fort Worth one time, and her jaws were locked, and her dentist had done a single filling on an upper second molar, and she couldn't open her mouth. Well, she had an existing centric relation to centric occlusion slide, a malocclusion, and had a pop and a click in that joint before the filling was done. So the dentist actually didn't cause it. His was what he did was just the last straw, and that disc, the retrodiscal tissue, completely tore and came forward, and she had an anteriorly displaced non-reducing disc, or a closed lock. So, or someone's got periodontal disease, or they've got fractured teeth, or they've got any number of things. I always tell patients I'm really a home remodeler, and before I redo your kitchen, I'm going to analyze your whole house and see what the foundation's like, see if you have termites, is the plumbing good, because I don't want to get into the kitchen and find out we've got all these other issues that are going to impact the restoration of the kitchen. I don't care if the person only restores the kitchen, but both of us really want to know what we're getting into before we start any definitive work. And that's why I do a comprehensive exam on every new patient, other than just getting them out of pain. If somebody was dying in pain with a tooth, we'd do something to get them out of pain, but I'm not going to do a crown on that tooth. I might do just something to get them out of pain until we've done the comprehensive exam. So these are some cases and examples of why I want to do a comprehensive exam. Well, this lady came to me with a restorative problem. She didn't like the fact her teeth were worn, but in the course of the exam, I also found out she had a significant intra-articular problem and was a big clincher. Now you see the abfraction here on these teeth. That's a sign of big time clenching. And so she had lots of wear on the anterior teeth. She was in a highly stressful job. That doesn't necessarily make you clench and grind your teeth when you're sleeping or during the day. But you want to know that, because restoring somebody like this is like restoring an Indy 500 car. Remember, big time clenchers and bruxers are like restoring Indy 500 cars. The wear and tear on the restorations is going to be about the same as it was on the teeth. So you want to talk about that ahead of time, and don't just put restorations on the teeth without the patient understanding what's going on, why it's imperative that they wear their night guard, that during the day, as they go through the day, they hum, meaning they lick their lips and go, and that puts their lips together and their teeth apart. Patients should know that the only time their teeth should touch is when they swallow. Your teeth shouldn't touch when you chew your food, and certainly the teeth should not be contacting each other, opposing arches as you go through the day. So if you'll have the patient just hum, tell them don't make that noise if they're around a lot of people, so they'll think they're crazy. And then wear a night guard or a dental sleep apnea snoring device at night so they can't grind and clench their teeth on teeth. Then you've got a high probability of the case turning out. But you want to talk about these things ahead of time. What do they say? If you tell somebody something ahead of time, it's a reason. If you tell them after the fact, after something breaks down, it's an excuse. So I want to talk about everything in the beginning and write it down just so the patient knows what they're getting into. So you can see the wear on these teeth. Just lots of signs, lots of stress on this system. It's an Indy 500 car. And think about those cars. They're built by the best mechanics and maintained by the best mechanics. But after that Indy 500 race, they're just beat to heck. Everything's torn up and has to be redone because it's been under so much stress and strain. So these cases are the same if you don't change the contact, the tooth-to-tooth contact, and have the patient change some habits. You can't make someone stop grinding and clenching their teeth. Some people say, well, they ground and clench their teeth because of a malocclusion, and once you even their bite and perfect their occlusion, they'll stop clenching and grinding. I've not seen that to be the case in my practice, and I treat lots of intra-articular and myofascial pain cases. It seems to me that if somebody is a bruxer and a clencher, they're probably going to continue bruxing or clenching, so you have to put something between the teeth, a night guard or a dental sleep apnea snoring device, during the times they're sleeping, and they have to wear it even when they're taking a nap. And then during the day, they must hum, just put their lips together and their teeth apart. Otherwise, there's nothing you can place on teeth, no restoration you can place on teeth, as someone once told me, that a patient can't destroy if they try hard enough. So don't make the patient's problem your problem. See all the wear here on these anterior teeth? Lots of wear here on the teeth. You can see she's had lots of broken teeth and crowns and endodontics in the past. Home care is not the greatest, so we've got to perk that up. And here are the TMJs. See, here's the auditory meatus, the ear hole. Here's the fossa. Here's the condyle. Here's the here's the disc. Way down here you can see it's very arthritic. And here it is also. Here's the auditory meatus, the ear hole. Here's the fossa. Here's the condyle, see all the arthritis, and here's the disc on the right side, very anteriorly displaced. Here's the left side, auditory meatus, here's the fossa, here's the condylar head, a lot of arthritis. Here's the disc, anteriorly displaced, auditory meatus, ear hole, fossa, eminence, condylar head open. Here's the disc, very anteriorly displaced. And so she was closed lock when I saw her. She couldn't open her mouth but about 20 some odd millimeters. Both anterior discs, both articular discs are abnormal in morphology, anteriorly displaced, and non-reducible, meaning the condylar head does not go back onto the disc. Once I treated her intra-articular problem and got her opening again to 45 millimeters, which is my objective with all of my intra-articular and myofascial pain cases. You can watch those videos in the library of dentistrymasterclasses.com. Then she wanted me to restore her teeth. So I'm increasing her vertical dimension. I'm not going to go through how I do that, but I'm increasing it 3 millimeters between the anterior teeth. There's a 3-to-1 relationship between the maxillary anterior teeth and the posterior second molars. So when I increase the vertical 3 millimeters anteriorly, I'm going to increase it about 1 millimeter to 1.5 millimeters between the molar teeth. So this is my working vertical, and this is my restoration. When you increase vertical dimension, you have to restore all the teeth on at least one arch, and you have to restore all the maxillary teeth with crowns. Again, I'm not going into that right now. This is not a seminar on how to increase vertical dimension, but I've restored all of her. These are maxillary teeth and these are mandibular teeth at an increased vertical. Lips in repose. So now we've got some tooth display with lips in repose with the increased vertical. This is lips in repose. Now remember, when someone has lost vertical dimension, what are the signs? How do you know they've lost vertical dimension? Well, normally they have lateral lines in the face, thin lips, downturned corners of the lips, Many times they'll have angular cheilitis in the corners of the mouth, meaning chafing and redness because saliva pools there. And I'll see patients that have been going to the dermatologist for that angular cheilitis thinking it's just a dermatologic problem. And then this part of the face looks like it's compressed. The nose is too close to the chin if someone has lost vertical dimension. Back in the day, they used to think, some very prominent dentists thought you never lost vertical dimension, that the alveolar process grew longer as the teeth wore. Well, early on, I had cases. This was the first case I ever restored, that had a vertical dimension issue. And I thought, what can I do to these teeth if I don't increase the vertical? And so I increased his vertical dimension. Mr. Downing, probably 35 plus years ago, and at the time I thought I was going to kill him. I thought people will die if you increase their vertical dimension, because that was the thought at the time. You can't increase vertical. And I went through it very carefully, testing it before I did it with his real teeth, and it worked beautifully. He lived another 30 years, 30 years in it, and other than just a little chipping, he loved it. Felt great, and it's a common thing now. So this is after I've increased her vertical. You can see how her face looks. That's her smiling before and after. So I want to know these things. We're talking about the importance of the comprehensive exam. I want to know these things before we get going. In her case, I didn't start by having a consultation on restoring all of her teeth. We only talked about allowing her to open her mouth, taking care of the intra-articular problem. I probably got the greatest collection of MRIs of the TMJ maybe in the world, because I've been taking them for 40 years of every TMJ, intra-articular or myofascial pain case. Once I'd done that, I had her confidence, and she said, what about the rest of these teeth? This woman had been to her dentist, and he was going to replace these two crowns, and I'd restored her sister. And her sister said, before you do that, you need to drive to Waco and let Dr. Cutbirth take a look at you and see if that's what you need. And you can see how her incisal plane and gingival line all slant from right to left. Look at the gingival line up here, gingival line here, and the incisal plane. And look at the teeth adjacent to these two teeth. The color of the adjacent teeth is not good, very mottled, and probably minerals in the water when she was growing up gave them a very unattractive look. And I said, no, you don't need me to do that. If you're okay with somebody just replacing those two crowns, you should go back to your original dentist, because anybody could do that, and it's not going to end up with a result that I would be happy for you to be walking around with and say, yeah, Dr. Cutbirth did this work. Because if I did a beautiful job of matching these adjacent teeth, you're not going to have an attractive smile. I'm not trying to talk her into it. I'm just saying I don't want to do it unless we can end up with a result that we're both going to be happy with. So once she looked at the photographs of her teeth, diagnostic photographs, and saw other cases like hers we'd done, she understood what I was talking about and said, yes, that's what I've been wanting someone to do, was give me an attractive smile. You can see we had old crowns on those teeth, some crowding down here. So the first thing I did was just establish an incisal plane on the central incisors. I couldn't make this one ideal, but I had to decide, where is my incisal plane going to be, and created an ideal incisal plane on that central incisor, which is parallel to the pupillary line. See, so this incisal plane is parallel to a line drawn between the pupils, which represents the floor, the horizon, the tabletop. Then I mark the gingival line I want to create, because I want the incisal plane and the gingival line to be parallel to the lower lip and the pupillary line, a line drawn between the pupils. So see, this is all going to line up now. I'm going to change the cant of these teeth and get the midline perpendicular to a line drawn between the pupils. So we're going to move the midline. We're not going to move the midline right or left. We're just going to change the cant and get this incisal plane parallel to the lower lip, the gingival line, and the pupillary line. So you can watch this case. The whole case is in dentistrymasterclasses.com. Once I took the crowns off the centrals, this tooth was dark, so I internally bleached that tooth. It had an old endo. And then I did periodontal crown lengthening surgery. Now remember, periodontal crown lengthening surgery is taught to me by Dr. Pat Allen, who's a world-renowned periodontist in Dallas, is not just gingivectomy. It's ostectomy and gingivectomy. So if the distance between the incisal edge of this tooth and the new gingival line is 11 millimeters, the distance between the incisal edge of this tooth and the alveolar crest has got to be 14 millimeters. From here, the gingival line to the alveolar crest must be 3 millimeters, and then you have to contour the interproximal. I'm not going through that in this seminar, but you can watch this case and others in the library of dentistrymasterclasses.com. So see, now we're squaring up. I've just placed provisionals on the central incisors. I've done the crown lengthening and all that. Now the incisal plane of those two teeth, the gingival line, is parallel to the pupillary line. I've only placed provisionals on the centrals, but that's parallel to the pupillary line, and I want the preparation of these teeth. I want the midline between the two centrals to be perpendicular to the pupillary line. I don't want it to cant to the side. You can't change the midline. You really can't move it right and left more than just a tiny little bit, but you can change the cant. And I've got an article and some videos on midline in dentistrymasterclasses.com. People don't notice a midline being off until it's off 4 millimeters or more. So it's really not that big a deal. If you look at some very famous people, they've got midlines that are off one side or the other, but I do want the cant to be perpendicular to the pupillary line, which is perpendicular to the floor. And then I want the incisal plane to be straightened up now that we've got our gingival line where we want it. So see, this now is parallel to the pupillary line, the preparation of the teeth. So we've veneered the teeth back to the bicuspids so we could change the shade of the teeth, and then I've changed the alignment of the gingival line and the incisal plane to make the gingival line and the incisal plane parallel to the lower lip line and a line drawn between the pupils, which represents the floor, the horizon, and the tabletop. See, so this did slant like this, and now we're square. And we've changed our shade. If you're changing shade, we're going to talk about that in a minute, you've got to restore at least back to the first bicuspid and ideally to the second bicuspid, so you don't have dark teeth on the side when somebody's smiling and somebody's looking at it from the side. So we restore it back to here. Now you can't remove all of this gum. You can't remove that because the average central incisor is 11 millimeters. You don't want a 14, 15 millimeter incisor. The longest incisor I've ever seen is 12 millimeters. So I limit the length of the incisor to 12 millimeters. The studies have shown that a smile that shows some gingiva is not unattractive if it's symmetrical. If the teeth are of normal length, just showing some gingival tissue like this is not unattractive. So you can see now the gingival line, the incisal plane, the lower lip are all parallel to the pupillary line. So we had to change all that or it looks funky. It's interesting. This woman, how she progressed in life within 6 months of doing this is just unbelievable. And it happens all the time. Is it her perception of herself, or is it other people's perception of her? Okay, now we're talking about the importance of the comprehensive exam prior to any definitive dental work. So this gentleman came in to see me, prominent person, retired, been going to the dentist all his life, just everything's patched up, patch. Lots of wear. This is just patched, leakage, decay here, something's going on here. So this is the upper left. These two teeth, you can see serious infection, and this gentleman's had heart issues. This is the upper right. See, this tooth is fractured, subalveolar crest. And so you decide, am I going to extract that tooth, graft it, and place an implant, or am I going to try to save that tooth? Well, if you take this tooth out, are you going to have enough vertical bone for an implant right here? Big question mark. Lower right, see all the bone loss around this tooth. Now remember, he's had stents, he's had heart issues, and so you don't want all that bacteria in the bloodstream, called bacteremia, flowing all through the body. Who knows what effect it's having on the other organs. And this is the lower left side, just lots of calculus and plaque. So I want to know this going in, and that's why all of my patients have a comprehensive exam and a formal separate consultation written out with it's. If you've watched my videos on how to do an exam and consultation, I write out what the patient said to me when they came in. Why are they there? This comes from the interview before I examine them. The results of the examination, and then suggested treatment, recommended treatment. So I'm not going to do anything that I can't stand behind. And with this gentleman, he'd just been going to the dentist, and when something would bother him, they would do something. And we're going to be a little more proactive, because I said, you don't want all that bacteria in your system. I don't know, where we're going to end up, because when we take those two teeth out on the upper left, there's so much bone loss from the infection, there's a good chance that I won't have enough bone for an implant. So it may be a removable flexi partial. We'll find out, but step one is get rid of the infection and all the bacteria. Deep cleaning. This woman, so she just wanted to have some lower teeth bonded. Had these old restorations on her teeth, and she came into the consultation, and that could have been done if she was okay with those old restorations. They're not my teeth. I'm just going to show her the photographs and then show her some other cases we've done. And so she and I were talking about just bonding these lower teeth, and her husband was sitting there next to her in the consultation chair. I always like husband and wife to come together to the consultations if possible. It's far more effective than just the one person to have to go home and translate to the spouse what I've talked about without the photographs of their teeth and the photographs of other cases and PowerPoints that we've looked at. So her husband was sitting there not talking, and I'd showed him cases. I said, just for the heck of it, let me show you what I would do if I were doing this ideally. If I were doing it ideally, you're an attractive woman, I'd replace these old leaky crowns. I would open your bite. You've got some vertical dimension loss, a lot of decay, leakage back here. And I just showed him these cases. So her husband was just sitting there, hadn't said a word through the whole thing. And she was just talking about bonding those lower incisor teeth that were worn. We were about to wrap up the consultation. He said, wait just 1 minute. What's that big job cost? And I told him, he said, we've been married 32 years. She's worth. I always have a hard time with that. Let me start that over. Yeah. Anyway, he said, let's do that big job. And so we ended up restoring her ideally. And we opened her vertical, waxed it up. This is the final result before and after. And you see what a difference it makes. You're not trying to talk somebody into something. You're just showing them what can be done because they don't know. People don't really know what their dental condition is most of the time when they come to see you. And some people will say, no, I'll just let it ride. Well, if they do, that's okay. The objective is not to talk them into something. The objective is to let the patient know what their condition is and what their options are so they can make an informed decision about what, if anything, they want to do about it. I'm not going to do something I can't stand behind. That's why we have the we have the comprehensive exam and then a separate formal consultation with the spouse, not just the individual person, but anybody involved in the finances. I want them at that consultation appointment so they can see the diagnostic photographs of the patient's teeth and the aesthetic restorative dentistry or the dental diagnosis books or the PowerPoint cases about what the treatment options are and what pathology looks like. So again, this is an attractive woman, and look what a difference it makes. So just show them what can be done, and then they'll decide. All right, this individual was a 75-year-old male, owned a large car dealership. He had continuous pain in an upper left second molar for over 6 months following endodontic treatment and crown placement. He had recently had extensive restorative treatment and complained that one or more of his current porcelain veneers came off at least once a month. He was constantly losing veneers. The treatment is following endo treatment. If the patient has pain on that tooth following endo, if the endodontics was done properly, chances are almost 100% that the patient's contacting on that tooth in some movement. If a patient has hyperocclusion on an endo tooth, even in eccentric movements after the endo's done, that will cause pain. So check the occlusion, check the occlusion, check the occlusion on all endodontic teeth, including eccentric movement. And I'm not going to clench really hard on articulating paper and be sure that they're not contacting in eccentric movements on that tooth. So here's the patient, had a bunch of these veneers that were coming off all the time. This is him before. So this was the tooth that had the endo through the crown. And see, it's been ground on already. The endo looks good, but look at that tooth. He's just beating the heck out of it. So there was little doubt in my mind what the problem was, the cause of the pain, the hyperocclusion or the occlusion on that tooth. So I adjusted the occlusion. He came back a week later and said, he thought I was fantastic, and all I did was adjust the occlusion on the endo tooth. And he said, well, what about these other teeth? He said, I'm sick of these veneers coming off. So we ended up restoring the rest of his mouth at his request. And this is him before and after. And this was done probably 10 years ago, and he hadn't lost a veneer since. If you place veneers the way I'm showing you, using Dr. Pascal Monnier and Douglas wrapping technique with the cementation technique I'm showing you, the veneers should be as strong as natural teeth. Watch that video, how to make veneers as strong as natural teeth. So he hadn't lost a veneer since. So here's veneers on the anterior teeth, crowns on the posterior teeth, veneers on the lower anterior teeth, crowns on the posterior teeth. And this is occlusion. You can watch my video on ideal occlusion. So after we did him, he said, my wife's having the same problem. So his wife came in, and she's losing veneers. So when somebody says they lose their veneers, I know there's probably something not right. The cementation process, the preparation, it's not that it's not right. It's just not the way I would do it to make them as strong as natural teeth. So she was losing these veneers too. So before, like this filling, I wouldn't put a veneer on that tooth. I would put a crown on it because you've got this MOD large filling. That tooth, chances are, is going to split when she bites down on something hard because there's nothing holding this side of the tooth to that side. So I'm going to use lithium disilicate Emax for the veneers, and I would just do a lithium disilicate crown on that tooth. So we redid her veneers and her crowns at her request, and that's been probably 15 years ago, and hadn't lost, she's not going to lose those veneers. They're going to be as strong as natural teeth. So we crowned that one before and after. This is a patient I saw recently. This is really interesting. I've had this happen twice. I saw a patient years ago that was a neurosurgeon's wife, and she was taking Neurontin for trigeminal neuralgia. And she'd been to several dentists, and they had treated her for, a toothache or a broken tooth or something like that. But I did the comprehensive exam. And I manipulated her into centric relation, had her touch, and she touched something real quickly. And I said, "Now, where are you touching?" She said, "Back here." Well, she had a single upper wisdom tooth erupted that had super erupted, and as soon as you started moving her teeth together in centric relation, that tooth contacted the lower second molar, and she had probably an 8 or 9 millimeter centric relation to centric relation slide, and her trigeminal neuralgia was in the upper left jaw. And I said, "Isn't that interesting?" So she'd been to several dentists, but they hadn't done a comprehensive exam. Now they were having her take Neurontin for nerve pain. It just deadens the pain, but it kind of deadens your system too, makes you groggy. And so I said, I can't promise this is going to take care of it, but I think there's a chance that may be your issue. So I took that tooth out, gone. That was the cause of the pain, which had been diagnosed as trigeminal neuralgia, because she'd been to dentist and they'd not found anything. Well, this woman came in the other day. Guess what? She came in for veneers, but in the course of her new patient interview in my private office, she said, "I've had trigeminal neuralgia since 2019. I said, "Really? Where?" "Upper left." I said, "Anything significant happened prior to that?" She said, "Well, I had a lower second molar extracted in 2015. I said, I said, "You were a night guard?" She said, "No." So I'm thinking, if you had a lower second molar extracted, you've still got the upper second molar. What if that tooth is super erupted like that other woman's had? So you can see a lot of wear and staining, a lot of wear on those teeth. Just been going to the dentist, just old broken down leaky fillings, this giant filling. It's just a matter of time until she splits those two teeth. See the crack right here, and this is all filling. So, and this is, all filling too, so those teeth are in big danger of cracking. Now, I'm not talking somebody into treatment. I'm just showing them with the diagnostic photographs what they've got. And then I'm showing them the dental diagnosis books so they can see other cases like theirs and how people get these cracks on their teeth and they split the teeth. They crack them into the nerve of the tooth. Once the crack gets into the nerve of the tooth, then you're talking about endodontics or a root canal as well as a crown. Or if you split it all the way through, you're talking about an extracted tooth and an implant or a bridge. So these are just teeth that have been restored with crowns to hold this side of the tooth to that side so they don't split it down the middle. You can see the big cracks and how this tooth is broken right here. So we're looking at those and looking at her teeth, and I'm just letting her see her own teeth. See, here's a big crack right here. Sensitivity on that tooth. These old cracks right here. Now this is the upper left second molar. This is the lower left first molar. The second molar was extracted. This is the upper left second molar. And when she's manipulated into centric relation, guess which tooth contacts? This tooth hits this tooth, and she's got about a 5 millimeter slide. Now, this tooth was extracted 4 years prior to her developing the trigeminal neuralgia. So, stay tuned for coming events. In the next few weeks, I'm going to equilibrate this tooth and take it out of occlusion. And I will bet that she really doesn't have trigeminal neuralgia, that she's got a malocclusion problem from a CRCO slide, significant slide on this tooth. But I wouldn't have known that if I hadn't have done the comprehensive exam and consultation. So in all these years, I probably only had a couple of patients say, I don't want a comprehensive exam, I just want you to treat me. Well, if a patient is that way, I really don't want them in my practice. I really don't, because they don't have an appreciation and understanding of dentistry. And I want to help them in a way I can stand behind it. So every patient coming into my practice gets a comprehensive exam and normally a separate consultation, unless it's something real easy. Then we may do it right there. And you can watch how I do the exam, interview, exam, and consultation in the Library of Dentistry Masterclasses.com. But it's amazing how many things come up in that comprehensive exam that the patient had no idea. And I'm not trying to talk them into treatment, but I want all the cards on the table before we start, and they do too. And then we decide on treatment and execute the plan. That's the Dental Minute. These techniques work, and they work every time. Click on the blue link in the description below and subscribe to dentistrymasterclasses.com if you want the really good stuff. There's a video library of all the Dental Minute cases, plus many, many other complete comprehensive cases, and a library of pertinent articles that all of us should read.